paranasal sinuses has very important functions such as the air conditioning of the inspired air, such as the humidification and warming, keep the nasal chambers moist, resonance to voice, protect the delicate structures in the orbit and the cranium. Orbit for the eye, it's protecting the eye, and the cranium, it's for protecting the brain. Lighten the skull bones, the rapid growth of face, absorption of shock to the face and skull, increasing the area of olfactory membrane and regulation of intranasal pressure. What's the rhinosinusitis? What is the sinus infection? In that slides, we can see there some sinuses. We know the sinusitis refers to inflammation of the lining of the paranasal sinuses. Because of the nasal mucosa is simultaneously involved and because sinusitis rarely occurs without concurrent rhinitis. That's why we call this rhinosinusitis is now the preferred term for this condition. In that table, we can see the classification of rhinosinusitis. It's classified as acute, it lasts up to 4 weeks, subacute at least 4 weeks but less than 12 weeks, recurrent 4 or more episodes per year with complete resolution between episodes. Each episode lasts at least 7 days, and chronic rhinosinusitis, it lasts longer than 12 weeks and sometimes less, just at 12 weeks. Classification of rhinosinusitis may be further classified according to the anatomic site. For example, maxillary sinusitis, which there is the problem in the maxillary sinus, or we call this the Heimer sinus. We call this the Heimerite sometimes, it's very popular terms. The ethmoidal sinusitis, which the problem is in the ethmoid sinuses, the frontal sinuses, and sphenoidal. Sphenoid sinuses we cannot see in the coronal section. It's the posterior sinuses. There are so many classifications about the chronic sinusitis, but in our program we will demand on you the Rhinogenic classification. It's classified as exudatively productive, alternative, mixed, and vasomotor allergic sinusitis. The exudative we mean the catral, serous, and purulent sinusitis. The productive we mean just the hyperplastic, polypoid, and cystic. Alternatively, it is the cholesteatoma, casus, atrophic, and necrotic. In the mix, for example, the purulent and polypoid, serous, and catral. It's very popular chronic sinusitis classification also. In the West world, they are accepted this classification. The chronic rhinosinusitis, divided chronic rhinosinusitis with nasal polyps and non-polypoid rhinosinusitis. Even in that endoscopic view, we can see the nasal septum, we can see the inferior turbinate, it's the floor nasal cavity, and very important, it's the nasal polyp. For example, it's the example view of the chronic sinusitis with the nasal polyps. But this also divided an eosinophilic and neutrophilic. The eosinophilic may be during the asthma, allergic aspirin sensitivity, allergic fungal sinusitis, non-allergic fungal sinusitis. But neutrophilic we mean antral canal polyp, cystic fibrosis, ciliary dysmotility, and during the Carter-Jenner syndromes. Okay, in that slides we can see all the sinuses view. We can see it's the paranasal, it's the frontal section, but coronal section, or during the coronal section we can see only anterior sinuses. I mean just the frontal, anterior ethmoid cells, and the maxillary sinus. But in sagittal section we can see the posterior sinuses. I mean the sphenoid sinuses, which located under the skull base, and posterior ethmoid sinuses. Even in that picture we can see the anterior ethmoid cells and the frontal sinuses also. Even we can see all the connection of the sinuses. Okay, in that slides also it is shows us the location of the paranasal sinuses. Even in that picture, we can see it is the pansinusitis diagnosis. Pansinusitis, we mean in all sinuses is damaged. At the same time, the right and left side and all sinuses, if damaged, we call this the pansinusitis. If one side damaged, for example, just the left side, for example, just the left side's frontal, left ethmoidal, and maxillary sinus is damaged, we call this the unilateral. I mean the unilateral. But sometimes only just the both of the maxillary sinus is damaged. We call this the bilateral sinusitis. The definition of is it's a group of disorders characterized by inflammation of the mucosa of the nose and paranasal sinuses. The same symptom, the nasal congestion, nasal discharge, sneezing, and the nasal itch. The pathophysiology of the sinusitis during the viral infection is damage the nose and sinuses, and when there is the valid anatomical abnormalities, all this leads to abstraction of the sinus ostia, and this reduce the mucociliary clearance. And it leads to the stasis of the secretion, and when it's trapped bacteria, we call this the secondary bacterial infection, and it leads to sinusitis. In that slide, we can see just the difference of the healthy and chronic and the patients chronic rhinosinusitis patients, the microbiome. We see it's just a whole. We can see the Haemophilus influenza, Staphylococcus aureus, Lactobacillus, Streptococcus pneumonia. All these we can see over it, but during the chronic sinusitis, it's not whole. After the damaging, even we can see this cytokine is releasing. Okay, in that slide, it's also interesting and shows us the difference of the normal cilia during the normal cilia with the back and forth propelling the mucus and trapping particles out of the sinuses. But it's during the cilia can become paralyzed during the acute sinusitis, and sinuses are congested with the mucus. During the chronic sinusitis, they may further damage the cilia. The mucosal lining becomes thick and scarred. The factors causing the rhinosinusitis. There may be anatomical predisposition factors and the mucociliary clearance. It's related. The anatomical factors, for example, agarnesis cells, over-pneumatized bulla, paradoxical turbinate, concabulosa, Halder cells, all these the predisposition factors. There is a mucociliary clearance. It may be the primarily and the secondarily. Primarily, we mean the specific disorders, but secondarily, we mean allergy, infection, and trauma. Okay, microorganisms, which is etiological factor during the acute rhinosinusitis, these are Streptococcus pneumonia, Haemophilus influenza, and Marxella catarrhalis. During the chronic rhinosinusitis, the bacteria causing acute rhinosinusitis plus the Pseudomonas aeruginosa and anaerobes. And that applies even we can see air fluid level of the mucus. The symptoms of acute rhinosinusitis, it's the constitutional symptoms, the fever, malaise, happens, the headache, and facial pain is very common symptoms. During the maxillary sinusitis, it's damaged the maxillary region and aggravated on stooping, coughing, and chewing, frontal. During the frontal sinusitis, office headache at the frontal. Ethmoidal, the bridge of the nose is so common symptom. During the sphenoidal, the vertex is more painful. And to the nasal discharge, nasal obstruction, redness, and edema during the frontal upper eyelid, the maxillary same region plus low eyelids happens. The symptoms of acute rhinosinusitis, it's the endoscopic view, even in osteometal complex. Okay, you can see it's the septum. It is the middle turbinate. This area is the osteometal complex, and it's the key region for us for putting diagnosis. The fever, congested nasal mucosa, lack of tenderness, mucopus in nose or nasopharynx. All these is the characteristic symptoms. The symptoms of the chronic rhinosinusitis, it's the usual list: no pain, no headache, the nasal obstruction is valid, nasal postnasal purulent discharge is valid, and hyposmia is sometimes is valid. This signs is the mucopus in the meatus, the nasal mucosa congested, and during the X-ray examination we can find the ear fluid level or opacity. The task for the criteria, how we can put diagnosis. For putting diagnosis of rhinosinusitis should be two major criteria or one major and two minor. The major criteria, we mean the facial pain and pressure, facial congestion or foulness, nasal obstruction or blockage, nasal discharge purulence, hyposmia, purulence on nasal examination, and fever. These are the major functions. The minor criteria is the headache, halitosis, fatigue, dental pain, cough, ear pain, foulness, and fever. In that table, you see it is the American Academy of Otolaryngology Head and Neck Surgery diagnostic criteria for chronic rhinosinusitis. It's written that the presence of at least two of the following cardinal symptoms for at least 12 consecutive weeks: the nasal obstruction, nasal drainage, facial pain, and hyposmia, and objective evidence on physical examination. For example, the mucopurulent drainage, edema, polyps in the middle meatus, or radiographic changes should be. The investigation, how we can put diagnosis, the radiological study is very important. During the radiological study, we need just the X-ray examination first, then the CT scan, and sometimes we need the MRI. But diagnostic nasal endoscopy is sometimes our gold standards. It's the nasal endoscopic view. You can will just examining with our flexible or rigid endoscope. Our important key point is the osteometal complex. It's the under the middle turbinate, this area. It's the schematical view. It's also schematical view. We see the septum, and this is the middle turbinate. Under the middle turbinate, this region is very important, and it's the patient's view. During the radiological studies, it's the X-ray examination. We can see opacity, but in that CT scan, it's the coronal section. In the right side, we can see the whole opacity, and the left side, we can see the ear fluid level. Okay, in that slides, it is also the coronal section, but it's we can see here the frontal cells, but this one is the axial section, and we can see just the sphenoid sinuses, opacity in the sphenoid sinuses. There are so many interesting CT scan, tomographic view. There's the bilateral, you see it's the pansinusitis. It's fulfilled with the nasal polyps. Okay, in that table you can see it's the table diagnosis and treatment of rhinosinusitis. During the viral rhinosinusitis, our treatment option is the symptomatic control, pain management, and we are using decongestants. But during the bacterial, we need to indicate prescribe the antibiotics. Okay, during the medical management, it's very popular. We are using the antibiotic therapy, corticosteroid, antihistamine, and nasal congestant. The management of sinusitis, our purpose first to eliminate of infection. That's why we are using antibacterial. We should eliminate the inflammation. That's why we are using anti-inflammatory drugs. recovery of osteopathology, that's why we are using decongestant and vasoconstrictors, and the drainage of the exudate in the sinus. For that, we are using a medical and treatment and invasive procedures also. It's the punctures. In that slide, we can see the punctures. Okay, it's very popular in the post-Soviet countries. And this one is the gamic catheter. It's also very popular in the post-Soviet countries. The surgical treatment may happen as the extranasal, for example, the Kalbe-Lux and Danger surgery, endonasal and endoscopic surgery. This in the slides you can see the Kalbe-Lux surgery. It is for doing the Kalbe-Lux surgery, we should just expose the fossa canina. We should insert through this hole into the maxillary sinuses, and we should create the connection between the nasal cavity and the sinuses. But because of the less traumatic approach, lower rate of the complications, and better preservation of antral lining, functional endoscopic sinus surgery has gained popularity for last decades against Kalbe-Lux procedure in treatment of chronic sinusitis in dental origin. The functional, it's the pictures when we are doing just a functional endoscopic sinus surgery. Shortly, we call this the FES surgery. For doing this surgery, we need the equipment, special equipment. What's the epistaxis? Epistaxis is the bleeding from the nose is called epistaxis or nosebleed. Epistaxis is a symptom and one should try to find its local and systemic causes. Approximately 50% population experience nosebleed in their life, but it is serious enough to seek medical consultation in less than 10%. Some patients present as an emergency. There is no age bar. Children usually have mild anterior nasal bleeding, while elderly have profuse posterior nose bleeding. Males are affected more than females, but after the age of 50 years, both the six sexes are affected equally. Epistaxis may be classified as anterior or posterior nosebleeds. Anterior nosebleeds are most common, usually occurring at Kisselbach's plexus in the anterior nasal septum. The Kisselbach's plexus consists of the anterior ethmoid, greater palatine, sphenopalatine, and superior labial arteries. More common in children and adolescents. Commonly caused by trauma, including nose picking. Approximately 10% if epistaxis occurs in the posterior nasal cavity in an area known as Woodruff plexus. The Woodruff plexus mainly consists of the posterior nasal sphenopalatine and ascending pharyngeal arteries, usually seen in the elderly, associated with hypertension and atherosclerosis. In that slide, we can see this the epistaxis, this the view. It means that the anteriorly, just remember that it's anterior, it's the key Kisselbach's plexus, and the posteriorly bleeding, it's originated from the Woodruff plexus. The Kisselbach plexus include just the anterior ethmoidal, greater anterior ethmoidal. This one is anterior ethmoidal, greater palatine, and superior labial arteries. Woodruff's plexus include the plexus of Wales, which is situated inferior to the posterior and end of inferior turbinate, is the site of posterior epistaxis in adults. What's the local causes for the epistaxis? The trauma, infections, neoplasms, environmental factors, drugs, and miscellaneous factors, they are the local causes. And the general causes, the cardiovascular, just the hypertension, mitral stenosis, congestion, heart failure, and each others. The hemopoietic, the aplastic anemia, leukemia, thrombocytopenic, and vascular purpura coagulopathies. It is the hemophilia. All this, it's the example for the hemopoietic bleeding. The nutritional, blood vessels, liver disease, kidney disease, drugs, and acute infections also is the are general causes. In the table, we can see the difference of the anterior and posterior epistaxis. The incidence of the anterior epistaxis usage is the more common than the comparing with the posterior epistaxis. The localization it's more approachable, it's easy in anterior than the posterior epistaxis. The common site it's the little area we mean the tissue baxus plexus. The age bar for the anterior epistaxis is the sometimes just the young people is damaging, but in the posterior epistaxis sometimes the elder people. Most common cause the trauma during the anterior epistaxis, but the hypertension for the posterior epistaxis, and the treatment we use anterior pack sometimes enough for the anterior epistaxis than the posterior epistaxis. We need to do the posterior packing. During the when we have just epistaxis patients, we should just check the hemoglobin. We should do some investigations. We should just check the hemoglobin. We should just the blood grouping, the bleeding time, activated partial thrombocytin time, and each other. The diagnostic nasal endoscopy. If we have the chance, we should do this procedure. And sometimes we should do this CT scan of paranasal sinuses. The general treatment in that slides, you can see that for the general treatment during the epistaxis. But by the step by step, we should just first the management of the epistaxis. We should just first do the general measures. Then if it doesn't help, we need to do the nasal cautery. Nasal cautery, we mean the chemical or physical cautery. We should do, if it is not enough, we need to do the anterior packing. If it is not enough, we should do the posterior packing. Then the next step is the arterial embolization. Then if it is not helped, then we need to do the arterial ligation. And the last step is the surgical treatment. Okay, the general measurements, all this, it's which we are doing during anterior epistaxis. We should just pinch nostrils, and we need to use the ice packs. If bleeding is continuous, we need to insert the cotton pledges with the adrenaline solution. If again it's bleeding, we need to do our second step, the nasal cautery. Nasal cautery, the chemical cautery. But then a chemical cautery we are using argentium nitrates, and electrical cautery for the physical cautery. In that slide, you can see the epistaxis set, or you can see it is the instruments, some drops which we are using, the yamic catheters, and just the Merocel gel foam. It's our first aid during the epistaxis. Okay, how we are doing the anterior nasal packing? Anterior, in that slides, you can see the anterior nasal packing. We should do this if bleeding is profuse or bleeding point is not localized. We are using a ribbon gauze soaked with the liquid with the decongestant. Can be done with vertical layer and horizontal layer, and can be removed with 24-hour and can be kept up to 2-3 days. Systemic antibiotics should be given to prevent sinus infection and toxic shock syndrome. In that picture, you can see the posterior packing. For posterior nasal bleeding can be carried through different instruments. You see, in that picture, we can see just a step-by-step of the posterior nasal packing. The first, we should just insert the catheter, then typing of bag to catheter type. Then guiding pack into the nasopharynx, tightening the anterior strips, and after that we should finish it with the anterior nasal packing. Okay, in that slide you can see the Simpson's nasal balloon, just aerosols, tampons, and each others. In that picture, we can see the difference of the anterior nasal packing and the posterior nasal packing. Okay, after the packing, we should do, if it will not help us, we should do the arterial embolization. If it is not also enough, we should do arterial ligation. Arterial ligation by external approach we can do, and sometimes we about the nasal trauma. During the trauma to the place, the most damaged part is the middle third part. And during the middle third part damaging, the nasal septum, nasal bones, and nasal septum is damaged, and we call this the fracture. The fracture of the nasal bones resulting in external nasal deformity and nasal airway obstruction from a deviated, fractured septum. It's important to correct the septal deviation when reducing the fracture. The nasal fractures has two types, the depressed and angulated types. This one in that picture we consider depressed. Due to the frontal blow, lower part of the nasal bones easily gives way. You'll see that the several frontal blow will cause open book fracture. Nasal septum is collapsed and nasal bone splayed out. And here we can see the depressed. It's example for the depressed fracture, and now we can see the angulated. Due to the lateral blow, may cause unilateral depression of the nasal bone on the same side and fracture both nasal bones and septum with deviation of the nasal bridge can damage also. And here we can see the schematic view of the angulated fracture. During the nasal trauma, nasal fracture, which symptom is acute? The clinical features of this is the swelling nose, this may be during the periorbital ecchymosis, the tenderness, the nasal deformity, perpetuous epistaxis, nasal obstruction, even nasal lacerations of the nasal skin may occur. Our diagnosis tool, the first is the physical examination. So we should just feel just a crepitation. Sometimes we feel it during the palpation, but for our that first gold standard diagnostic tool is the X-ray. Here, during the X-ray, we can see may or may not show the fracture, but patients should not be dismissed as having no fracture because X-ray did not reveal it. The treatment methods of it, the simple fracture with no displacement, there is no treatment. But there are two types of the reduction, the closed reduction and open reduction. Sometimes we are doing the closed reduction. It's interrupted by presence of edema. This time is before the appearance of edema or after it has succeeded. Usually 5-7 days, difficult after 2 weeks because it heals by that time. For example, in this slide we can see the closed reduction. Closed reduction is usually reserved for simple non-communicated nasal fractures. Also exceptions can be made, and this one the fractures reduction instrument for acute nasal fracture management. In lateral displaced fracture, okay, we are using with this method. Okay, the possible complications of the broken nose include just infection of the nose, the sinuses and the facial bones, the permanent breathing difficulty, the persistent drainage from one or both nostrils. It's very serious complications because it may be caused by the cerebrospinal fluid draining from the brain into the nose. We call this a rhinorrhea. Change in the appearance of the nose or the tip of the nose, the crooked or deviated nasal septum, a hole in the nasal septum, the septal perforation may occur, An accumulation of blood in the nasal septum. We call this the nasal septal hematoma, a change in or loss of the sense of smell. And septal hematoma and the septal abscess can occur. What is the septal hematoma? The septal hematoma is a collection of blood between the mucoperichondrium of the nasal septum and the septal cartilage. The pathophysiology of this: the nasal septum is subjected to sharp buckling stress, and the submucosal blood vessels are damaged. If mucosa remains intact, it leads to formation of the hematoma. If the trauma is severe enough for the fracture of the septal cartilage, the blood will seep to the opposite side, causing bilateral septal hematoma. Here in the slides we can see the treatment methods of the septal hematoma. During the septal hematoma, the prompt aspiration drainage is very important. After the drainage, we should do the packing or splinting and prophylactic antibiotic therapy we need. Hematoma acts as an ideal medium for bacterial proliferation and colonization. If left untreated, it gets infected within 72 hours and leading to the formation of septal abscess. The nasal septal abscess, which we call this the NCA, the nasal septum is an essential structure maintaining the external shape and function of the nose. Nasal septal abscess is defined as a collection of pus between the cartilaginous or bony nasal septum and mucoperichondrium or mucoperiosteum. The etiology of the nasal septal abscess: it's the secondary infection of the septal hematoma. The funcule may be in the vestibular part or upper lip. Acute infections such as the typhoid or measles, and sometimes the diabetic patients, they are more prone for the septal abscess. In that slides we can see the anterior rhinoscopic view of the nasal septal abscess. We see the tenderness, we see the erythematous, swollen nasal range during the anterior rhinoscopy. Typically demonstrates tenderness fluctuation if we palpate it, of unilateral or bilateral swelling of the nasal septum, and that narrows the nasal cavity. Okay, in CT scan, it's the coronal CT scan image showing expansive swelling of the septum. The complete bilateral nasal, in that patient, there is the bilateral nasal airway obstruction is occurred. What we should do during this, our management, we should immediately do incision and drainage this abscess. On incision and drainage, thick yellow pus was recovered, and after that, after the drainage was left inside the abscess cavity, and nasal splints were placed bilaterally to compress the septum. The complications may occur. Delayed diagnosis and management of nasal septal abscess results in a compromised vascular supply to the cartilaginous nasal septum and sedonal deformity as a final cosmetic complication, maybe. And other serious complications are the sepsis, meningitis, orbital cellulitis, cavernous sinus thrombosis, intracranial abscess, and we'll have just separately lectures about this. Thank you for your attention.